Thank you very much, Eric. Can you all hear me? Okay. All right. So now we're going to venture into the world of glaucoma. So we're going to talk about the TrabEx PRO, which is a way of performing goniotomy. And why do we like goniotomy? It's a straightforward procedure. It has a long history. It's been around in ophthalmology for a very long time. We don't have to worry about a foreign body over the long term. In some ways, where we're doing it, I operate temporally, so we're always doing it on the nasal aspect for the first time. So it's a straightforward procedure. In general, the cost to the facility is more favorable. In our setting, our ASC, it's one of the less expensive procedures that we do in using MIGS devices. And we can use it in combination with a lot of other surgeries. I do a lot of combined opening up the canal and then putting a stenting procedure behind it. So this is a procedure that kind of facilitates in a lot of cases using a trabecular bypass device. So the TrabEx, which is an iteration of the TrabEx PRO, is an iteration of originally the TrabEx, which is an iteration of trabectome. It's the kind of the grandfather of things in this space. So it has very polished blades, which makes the kind of the passage in the when we're in the canal straightforward. It has a trapezoidal, so I think it's important that we open up and create space when we perform a goniotomy. I think for longevity of effect, it's better than the tearing procedures. The difference in TrabEx PRO is we do it under irrigation and aspiration, which is it helps facilitate the procedure. Sometimes maybe there's not that much different, but other times I find that enhances even the passing of the device, but also just clearing out of debris as we do it. And we'll go over the details when we look at some videos about how they're trying the procedure. So the way this is engineered now, it's through our normal cataract incisions. The sleeve is watertight, so there's not a lot of leakage. For those of you who maybe done trabectome in the past, you'd had to kind of titrate the flow just right to keep the chamber maintained throughout that procedure, especially when you put the irrigation portion of the procedure on. So we see this trapezoidal blade. You can kind of tilt it out and do more of it with the tip. But ideally, if you want to remove a strip of tissue, once you have the tip kind of started, we'll basically slide it with the back of the plate there to facilitate formation of the goniotomy. And once it's in place, I typically, and we'll see this in the videos in a second, place it in the canal, apply a little suction, which actually helps bring the trabecular meshwork forward and facilitate the passage through the canal of Schlemm. And when I do this procedure, I typically am aiming for about a 2 to 3 clock hour goniotomy. So when we presented some of our preliminary, so we've been using the TrabEx PRO for about a year or so now. So we presented some of our preliminary results at the WCGC meeting in Rome back in June. And here you see basically a sample. This is what we want to see at the end of the procedure. This is a good goniotomy, which is very, achievable with this device. But what we found in this patient population, which we combined this in combination with cataract surgery, much as other MIGS procedures, starting eye pressures on a couple of medications was in the low 20s. On average, we got pressures down to about 15 or so. So this is really what, in this mild to moderate glaucoma population, this is really pretty much what we want. Ending up, with decreasing the medication load. In this case, so they went from an average a little over 2 down to a little less than 1, with achieving pressures in the mid-teens. So this is really, what this procedure can achieve and very consistent with other in the literature. When we look at the common complications of the side effect, the most common complication, and this is true of most goniotomy procedures, is microhyphema. So some blood cells were visible in the anterior chamber at post-op day 1. Once again, I actually kind of, in some ways, like to see that a little bit. You just don't want to be at the hyphema. And we found that most patients, that was transient. By the next week, at week 1 post-op, that largely went away. There's always a little bit more manipulation when you do any of the MIGS procedures. Some patients had a little bit more corneal edema than none in the first day. Once again, largely resolved in the first week. IOP control, and I think that's one of the arguments for patients who do have glaucoma or are at risk for glaucoma, doing combination goniotomy along with cataract surgery. So here's an example case, and we'll look at a few videos here. So here we see visualization. We'll see the irrigation start, and the foot plate pays it. We see we're underneath the trabecular meshwork and just sliding every so. So once we get started, it's nice to turn the tip away from the back of the Schrumpf's canal because it's easy to kind of get caught in there. As you're sweeping and changing your orientation, you have to be cognizant that if you're still pointed down like you did at your entry, you'll kind of skip along the back of the canal and kind of cause micro perforations. So ideally, in this particular case, I always like to, or most of the time I like to, I put a little viscoelastic, especially in the cases that I may be doing a combined procedure, but this is more for it's not inherent in the procedure, but to demonstrate the extent of the goniotomy. So I like to always just check. You can often see it. And the nice thing under continuous irrigation, you're kind of spreading and forcing BSS into the canal as you do it. But also viscoelastic at the end of the procedure is nice to kind of highlight how much of a goniotomy. And usually, once again, the target is around between 2 and 3 clock hours. Just another case, and I think utilizing trypan blue is especially helpful in these cases. This is the case actually where we had already placed had a hydrus placed, and then we used the TrabEx PRO to create the goniotomy afterwards. Most commonly, I create it earlier, but you can see that with the trypan blue, the nice thing about trypan blue, it stains the non-pigmented trabecular meshwork as well. So we often see pigment, and that's really only the back 50% of the trabecular meshwork. If we're just targeting that, we have a higher chance of going posterior where we'll hit some vascular structures. So we have to remember that the anterior portion in many eyes is non-pigmented, and that's really where we want to target. We really want to target the upper junction of the pigmented trabecular meshwork, much as the protocols were from we did ALT, because once again, there is a portion of the trabecular meshwork which is not always readily visualized. Here's one more case at the end of the cataract portion. Put a little viscoelastic. You can put trypan, if you do use trypan, which I am an advocate of, you can do it at the beginning of the cataract surgery. A lot of times it'll stay there. Sometimes it might get a little white by the end of the case. In this case, we use trypan, not so much for the cataract portion, but to help us to visualize the trabecular meshwork. So we put that in, turn the head like usual, put our gonio lens on. And then the nice thing about using the TrabEx PRO device too is because of the irrigation aspiration, it'll wash away any excess. So if you do trypan in this stage after the IOL is put in, it'll help irrigate out the residual. My video is a little choppy here for some reason, but it'll help visualize the trabecular meshwork. And we see a nice blue band here. It's obvious where the trabecular meshwork is. Once again, we see this kind of anteriorly lightly blued portion, but that's trabecular meshwork too. And so we really want to target that area and make our sweep anterior to kind of the darker blue band. You can see the lifting that you'll get once you apply. So once it's in place, apply irrigation and aspiration, and then the aspiration actually facilitates the lifting of the TM. It's much easier to get that underneath the tip of the TrabEx device as we move it along the canal. I don't know why my video is so choppy. But once again, kind of really, I find that with goniotomies, it's best to just do it where you can visualize straightforward. So going to extremes is often with a goniotomy device is when we can get into problems when we're trying to use a sharpish device in an area where we don't have good visualization. So once the goniotomies form, in this particular case, this is the case where we did put it in combination with a hydrus. So you'll see applying some viscoelastic will basically identify the goniotomy space. And if there's ever an issue, this is a very nice kind of trick for placing a hydrus. If there's some kind of worry that you might not be able to find it or you're having problems getting the canal, because once this goniotomy space is blown open, it's very, very easy to place the hydrus. So once again, we see that with the viscoelastic place, we see the goniotomy opening up nicely, and then it's a very, very easy target. We want to place the hydrus at the very end of that. So we got about a 2.5 clock hour, 3 clock hour goniotomy, and then we'll watch it. We'll put the hydrus in right at the very distal end of that, and there's no resistance, and this is really, I think, the technique that's easiest for placing that in addition. So here we see that being placed through a paracentesis, which I usually like to make a separate paracentesis to place the hydrus. We'll place it in the end of our goniotomy. And there it is. So we basically get right under that end of the little flap and then just dial the hydrus into place. And it's in. So there's not really any bending. There's very little resistance, and it's easily placed. And then usually I just take the device and just shove it along. And once again, it's really effortless. There's no doubt we're in the right place in the canal. And it's besides getting probably a little bit of more increased efficacy is what we find, the hydrus is easily placed. So, goniotomy is effective for glaucoma. It's probably, of all the mixed procedures, the most straightforward one we do. The reimbursement has been stable, and hopefully in the current environment will remain fairly straightforward. And we have a long history with irrigating aspirating with trabectome. I don't think trabectome was a useful device, and once again, the pioneering device for ab interno trabeculotomy or goniotomy. It had some other issues in terms of expense, kind of a little bit cumbersome to use. This device has really taken the positive attributes of that, taking advantage of once again, if we do this in combination with cataract surgery, we can do it but also as a standalone. The nice thing, if we do a standalone, we don't have to even use viscoelastic if we choose not to, because it's there in cataract surgery, we often do, but it's not requisite in the procedure. So the other thing is, when we're under continuous irrigation, the visualization is not a problem. We find that, especially in some eyes, the patients are turning a bit. We are basically always pressurizing the eye. We don't have to worry about viscoelastic leaving throughout the procedure because we're constantly infusing BSS into the anterior chamber. So the view is good. The eye is safe because there's space been made in the angle, and we don't have to keep stopping and reapplying viscoelastic. So that's all I have prepared. Are there any questions? Okay. Thank you very much for coming out. Please let me know if you have any questions afterwards.